Good morning, everyone. Thank you for attending virtually and in person. Morning Grand Rounds, June 2nd edition. Dr. Kassam isn't able to be here today, so I have the opportunity of introducing our speaker. But before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And with that, I would like to introduce Dr. Monty Ghosh. Monty Ghosh is an internist and addiction specialist. He works with multiple community-based not-for-profit organizations to provide support for equity-deserving populations, including the Calgary Drop-In Center. He also helps foster and create unique programs to support those living with substance use, experiencing homelessness, and other vulnerabilities. He is the medical co-lead for the AHS Rapid Access Addictions Medicine Program and the medical director for the Addiction Inpatient Service at the Foothills Medical Center, Rocky View Hospital, and South Hills Campus Hospitals in Calgary. He's an assistant professor at both the University of Alberta and University of Calgary, and is involved with provincial policy building in Alberta, as well as research, and is the primary recipient of grants from Health Canada, Alberta Innovates, Alberta Health, and the Canadian Institute of Health Research. He co-chairs AHS Vulnerable Populations Task Force. He's also the co-chair of the Canadian Network for the Health and Housing of People Experiencing Homelessness. Dr. Ghosh recently received the University of Alberta's Community Leader Award for his work with addictions and harm reduction within the community. This prestigious award honors those individuals and groups who have embodied the U of A's promise to uplift the whole people by sharing their expertise, time, and energy for the benefit of the public good. It's my privilege to introduce Dr. Ghosh.
Thanks, Dr. Ringrose. Really appreciate you allowing me to be here today and allowing me to talk about harm reduction in acute care. There's a lot of people here. I know some of you guys on the call or on the virtual session have experience with this already, and some of you don't. So happy to answer questions towards the end and talk about the importance of harm reduction. First and foremost, as Dr. Ringrose had already done, I want to acknowledge that I am on Treaty 6 territory. I also work at a Treaty 7 and Treaty 8 territories as well. So grateful for the opportunity to be here as a settler. And this is my disclosure slide, copyright slide. And so yeah, these are learning objectives today. So we're going to talk about the definition of harm reduction. Understand that there's 5 types of harm reduction, and actually I'm going to introduce the 6th one today, and then discuss issues with substance use in acute care and discuss how to implement harm reduction in these particular settings. I won't dive into addiction treatment per se as much, but really focus on the harm reduction aspect and the philosophy of harm reduction. So when you look at the pillars of public health's response to substance use, we've got four main aspects. You've got enforcement regulation, we've got prevention, which is education. We've got treatment, which is things such as residential treatment programs, opioid agonist treatment programs, but then we've got harm reduction. And harm reduction, of course, is what we're focusing on today, but it is a crucial part of any sort of management plan with any individual who has a substance use concern. And so what is harm reduction? It's a set of policies, programs, and practices that aim to primarily reduce the adverse social and economic consequences of use of legal and illegal psychoactive substances. The way that I look at harm reduction is really about improving someone's quality of life. And if you look at it through that lens, a lot of it does make sense. It's all about making sure that people are the healthiest selves that they can be. It's that their quality of life, whether that's their social aspects of their quality of life, whether it's their health aspects, their justice aspects, are all maximized and improved upon. And it's also about empowering individuals. It's about enhancing the ability of people who use substances to have increased control of their lives and their health. And it's very much a compassionate approach. It's recognizing that people don't have to go towards abstinence, but recognizing people can be the best selves they can be, and try to encourage that. And we do harm reduction on a regular basis. We do harm reduction when we wear a life jacket and we're out in the lake. You don't want to drown, of course, right? And we do it when we drive to work. We do it when we bike to work. So seatbelts and helmets, of course, on bikes are definitely harm reduction strategies. These are activities that we do on a regular basis that can be potentially detrimental, that can cause injury and harm, but yet we take precautions to make sure that we're okay. Doesn't mean that we stop it altogether. Some other examples of harm reduction include server intervention programs, which decrease public drunkenness, environmental controls and tobacco smoking, impaired driving prevention campaigns. So this is more of the educational aspect of it. And then housing initiatives that look at managed alcohol, where we dispense alcohol to clients to minimize the risks of overconsumption, non-beverage alcohol use. And it's part of the spectrum of substance use management. So when we look at the safest approach to say injection practices versus the most harmful, of course, is sharing, lending, selling, and borrowing equipment, where the safest, of course, never injecting. But most and many individuals, I should say, can't reach one or the other. And so this is where really harm reduction comes into play. This is where you provide them with sterile equipment. You encourage them to clean their own equipment. You talk about not sharing and lending. So these are the things that you can enforce with harm reduction supports. And so the question is, how does it fit the overall treatment of not just opioid use disorder, but any substance use disorders? And these are from the CRISM guidelines. So back in 2017, the Canadian Research Institute of Substance Misuse provided some guidelines around opioid agonist treatment management. And part of the management included both medication management and psychosocial management, which is very important for addictions. But last but not least, harm reduction approaches. And harm reduction spans the entire spectrum of managing substance use disorders, whether it's medication support or even psychosocial interventions or even supporting their mental health. Harm reduction should be included in almost every discussion that you have with individuals who are using substances. And there are 5 main components to harm reduction. And as I said, I'll introduce the 6th one today. The first is education regarding safer use. And so one of the key principles of harm reduction is that you have to provide information to individuals about how to use substances in a safe way. And some of this is public health messaging. So the biggest message that I often say to individuals, because it's my special interest area, is that you should not use alone. Have a friend check on you, use a physical supervised consumption site if available, because that is the gold standard. But there's other options, which I'll talk about in just a bit as well. And to do a test shot first if you're going to be injecting a new substance. If you see that there's a new color, odor, or smell, be very, very careful and start slow and use a low amount of dose. Mix your hits yourself so you know what you're using. Don't mix substances with other what we call downers, such as alcohol, benzos that are depressants. And then also carry an naloxone kit and make sure that you have someone nearby who knows how to use it. And of course, call 911 if needed. You can see in the diagram here on the right-hand side that there's safe injection areas and there's areas that we try to avoid, and we try to encourage patients and individuals to utilize an area that's safest for them, although that's not always possible. So you want to just encourage them to be the safest they can be. So number 2, in terms of the aspect of harm reduction, is access to sterile syringes and needles and other supplies. This is from the ARCHES program in Lethbridge, but the kit is from the ARCH program, which is a great program in Edmonton at the Royal Alex. And really it's about providing clean and sterile supply. Don't get increased harm from contaminants. So some of the key features of needle in exchange, syringe exchange programs includes having them located where substance injection is most prevalent, provide clean paraphernalia to reduce transmission of bloodborne pathogens. It serves as a really important contact point, and it's using the concept of low threshold interventions. And what I mean by that is that it's very difficult for a lot of individuals to access care because of stigma, trauma, and sometimes just barriers such as geographic barriers, just accessibility. And so having these services close to them reduces those barriers and provides an easy contact point for them to enter the healthcare system. It's a space where you can provide health promotion information, so safe set practices, and also do STBBI testing, but it goes beyond that. It can be a place where they can access other services such as social services, taking care of those social determinants of health that are so important to deal with and manage for these patients. And there's a lot of evidence to suggest that these are really, really essential. Part of the history of these programs stems from the HIV epidemic that occurred back in the 80s. We know from back then that there was a lot of spread of HIV, and there was a lot of harm reduction interventions that were done to sort of mitigate this. And actually, that's really where the birth of harm reduction is. It really comes from the infectious disease world, but it's moved into the substance world. And we know that since the implementation of various syringe exchange programs, especially from some studies in the United States, they found that there was a decline by an average of 18.6% infection rates within 36 cities who had needle and syringe exchange programs, where it increased by an average of 8.1% annually in 67 cities in the United States that lacked these programs. And there's also one thing to sort of highlight is that there's no convincing evidence of major unintended negative consequences from these programs. And so in terms of the evidence, it really overwhelmingly supports a reduction in self-reported risky injection behavior. It reduces HIV transmission, Hep C transmission, and it really has a positive impact in facilitating entry into retention treatment programs. And in terms of some common objections that we hear, they often say that having access to clean needles makes people less likely to quit using. So this was a prospective study that was done in Vancouver. And what they found was that really when they followed these individuals over a time period and looking at their injection practices, that there was actually a reduction in overall use of substance use. They found that by engaging with healthcare services, that people are more likely to enter treatment and enter supports. And that went from 2.4% at the start of the program to 47.9% thereafter in 2010, so almost 14 years after the initiation of these programs. So that's quite remarkable. So another common objection is that there's more dirty needles out there because of needle syringe exchange programs. So this was a pre-post study that was done in the United States, and they demonstrated that there actually was not an overall increase. Yes, there is some needle debris that does occur, but there's a lot of program that's built around that to help prevent that. And there's a lot of encouragement for clients to sort of safely dispose of their syringes. And it's all about education. And so there's again this fear that there's increased needles out there, but that hasn't really been proven, although people often do say that. So how should we do this? How should this be provided? So we want to aim to provide full coverage of clients' injection needs. You want to you don't want to provide a restriction around the number of needles and syringes, and the insistence of returning the equipment that can be counterproductive. And you also want to be and ensure that there's secondary distribution as well. So that's another safe way of providing. So you provide extra needles, extra sterile supplies so that clients can provide this to other clients as well that may not be necessarily accessing these services, and encourage them to come back. And then other paraphernalia should be distributed as well, including alcohol swabs, sterile water filters, mixing vessels, and acidifiers. And again, one of the key pieces to this is testing. So it's a great place to provide testing for STBBIs. And it's also a great place to sort of engage with education around safe transmission practices. Another aspect to this is outreach. So I kind of clumped this in with sterile supply exchange, but really it's all about community outreach and reaching these individuals, and again, providing that low threshold intervention that's so required for this group, because again, they don't necessarily access services. And so you want to be able to engage with them. You want to be able to reach these hidden populations who often don't want to engage. The third aspect to harm reduction is take-home naloxone kits. It's a key thing. This was very controversial when it first came out, and I'm glad the controversy's gone around this. It's an absolute necessity. You guys all know that naloxone kits are the sort of the antidote to drug poisoning events from opioids in particular, from illicit substances such as fentanyl. And these are some old numbers, but we've really distributed over 80,000 kits actually in the last year. And so it's incredibly important to have these being distributed, and they are life-saving measures. And common objections that we used to hear from back in the day is that having access to naloxone kits makes people feel like they can use more drugs. And that is absolutely not true. There's been a few studies that demonstrated that that's not the case, especially with some of those cohort studies out of Vancouver. There was a study that was done by our very own famous Dr. Dong and Marlis Taylor in Edmonton that looked at this as well in Edmonton in particular with Boyle Street, and found again that there was no increase into people's substance using habits because of naloxone. In fact, there was more likelihood of them engaging with services to actually obtain these kits and use safely. Also, another common objection is that allowing substance users to reverse an overdose without being admitted to hospital delays entry into drug treatment and allows people to continue using opiates without facing some negative consequences. And again, this is not true. So there was a study that was done out of New York, where they looked at the rates of people calling who were using substances who had a naloxone kit versus those who were not, and they found that 74% of participants who had called for help after administering naloxone, or was what they saw, which is similar to the general proportion of individuals who are using substances who call for help as well. So really, no changes. The fourth big arm to harm reduction is access to supervised injection sites. So we have different names for these: supervised consumption sites, supervised injection facilities. You'll see these different names in the literature. I think the most appropriate name, of course, is supervised consumption sites, because there's just not one route of consumption, although many of the sites do focus on injection. We do have some routes that focus on inhalational supports. And this picture is from one of the first sites that was ever developed. This is called Insight in Vancouver, and it provides both a harm reduction facility on the bottom floor, but also there's detox as well that's attached to this, where people can access other services. And it's really meant to help and support those who are most vulnerable. So these are people who are likely to be of lower age, report public injection use, who are experiencing homelessness and unstable housing, and have a variety of substances that they do inject. And it's really one of the gold standards for providing support for this population. Since the facility's opening in Vancouver, which is again North America's first big site, there was an associated 30% increase in detoxification use, increased rates of long-term addiction treatment initiation, and reduction around injecting, specifically around the supervised injection facilities. And there's also a reduction in risky practices. So the use of these sites it was associated with decreased syringe sharing, because people were accessing the site, getting clean and sterile supplies. Women reporting diminished threats of violence in some of these facilities, especially the women-focused facilities. And clients were more likely to report using sterile water, alcohol wipes, and other equipment that is very crucial and important to use to prevent and reduce the transmission of STBBIs. And I think the biggest thing is that there was a reduction in overdose mortality. So to date, there hasn't been a single death at any of these suppressed consumption sites. They've found that within a 500-meter radius, and this was a pre and post study that was done in 2011 in Vancouver, that there was actually a reduction of overdose rates within that radius. And then there was a trend towards a reduction up to a kilometer around facilities. And so this really highlights the importance of having as many of these facilities as possible, having them scattered around, decentralized, and providing supports for clients as needed. There's a lot of controversy around public disorder around these services. This is from one particular study that was done in Vancouver. They found that when they looked at sort of linear regression models in a 12-week period, looking at pre and post the implementation of the program, that there was a reduction in the number of public substance using, public syringe discarding, and also public arrests. I know that a lot of objections have happened around this. In Calgary, for example, there was a police report that happened around supervised consumption site in the Sheldon Schumer. But if you look at those results, there really wasn't a difference in terms of a statistically significant difference between disruption before the implementation of the site versus afterwards. And so I think that's important to note, that while there might have been sort of seasonal variations, there might have been an increase in percentage points. When you statistically look at that data and statistically look at that information, it's not true. Another big fear is that having these facilities will encourage substance use and initiation to drug use. And again, based off some of these prospective studies that have happened, that's not true. So this is the prospective cohort study that was done in Vancouver again, and they found that out of 15.9 years, that only one individual ever reported using their first injection at these physical suppressed consumption site facilities. And in fact, it was more so the opposite. People would stop using injection routes. They would be utilizing things more safely. They were engaged with more treatment supports and wellness supports in general. So I think that's very, very important to highlight. and this is sort of another a slide around crime. I think I spoke to this point already. So there's another fifth aspect that has popped up around harm reduction, and that's safe supply. And so this is the concept that we can replace an unpredictable illicit supply with something that's much more that's prescribed and predictable and doesn't necessarily need to be prescribed. I think that's important. I think many of us are thinking that from a public health perspective, this should be provided by public health and potentially purchased by individuals who are using substances. It's a very radical form of thinking, and I get people's apprehension around this. But if you think about it, when you have an unpredictable drug supply that's being contaminated with benzos, xylazine, other substances that are very potent and at concentrations that you can't predict as well, it makes sense to have something that's an alternative. The evidence, however, is still pending. There was a study that was done by Tara Gomes back out of Ontario, out of London, Ontario, that looked at the outcomes around people who are entering a safer opioid prescribing program in Ontario. And what they found was that there was an overall reduction in ED visits, a reduction in hospital admissions, no change to the rate of infection. There was 4 less overdoses and deaths associated with this program compared to a matched cohort that they looked at a 4-to-1 ratio. But there wasn't any differences otherwise. And it was looking at a sort of a matched cohort of about 90 individuals who were part of the program over time. I'll jump back to the other slide in just a second, but there's also other types of safer opiate supply programs out there. So this is the biometric dispensing machine. So this study was done by Jeff Bardwell and Thomas Kerr, and really it was a program that came forth from an idea by this investigator called Mark Tyndall. And it really is a machine where people can use their biometrics using their palm to get access to hydromorphone. And so some of the things that they found from this qualitative study was it provided a stigma-free space for substance use, provided easy access in terms of timing, flexibility, and reduced illicit substance use, and reduced self-described overuse risk, and improved health and well-being for individuals. Not everyone feels this way. This was a commentary piece that was done by another doctor that they sent into CMAG. And I think the verdict's still out there in terms of the benefits and the risks. And I think that's important to recognize, is that while there's no evidence to necessarily suggest that there's a reduction overdose risk, the concept makes sense in many respects, and that it really provides another space for individuals to use substances safely. And again, while the research and the evidence is sort of evolving around this, we just need to be aware that there's benefits and consequences, and there's no evidence for harms associated with this as well. So I want to highlight that too, is that while we may focus on anecdotal evidence of harms around this associated with this, there's no actual evidence around that too. So it's very, very important to sort of recognize that piece too. The sixth arm of harm reduction in my mind is drug checking. And so this is happening more and more often. So there's lots of drug checking that already occurs. So for example, whenever there's a confiscation of substances from the police force, for example, that gets sent over to Ottawa for testing by the RCMP, it's been something that we've been doing for a long time, but it hasn't been accessible necessarily to the public. And I think that's the key piece. It sort of enhances the education around substance use. And we're starting to see more and more of this. So AWARE, which is a group that's based out of both Calgary and Edmonton. So it's Alberta advocates who educate and advocate responsibly are doing this right now. And so they're going to be doing it at physical supervised consumption sites. We're also doing wastewater testing in Calgary, and soon to be in Edmonton as well. Edmonton's already had a wastewater testing program for substances by StatsCan, but it should be expanding soon. And so we're looking for trends in substance use, trends in increases of carfentanil, for example, and new compounds that might be entering the substance use market. And we're trying to figure out ways to sort of alert the population towards this. It's all about sharing this information with people who use substances, most importantly, but also healthcare providers too. I mean, recently in Lethbridge, we saw a whole slew of cases for people who are using substances, who are using opioids, who are having Parkinsonian type symptoms, who we thought might have had serotonin syndrome. And so it's really important to sort of determine what was going on with those substances. What were they using that was causing this? And drug checking provides an avenue for that. I was going to take a moment to share some of my work around this area in this space. So a program that I'm working on is called the National Overdose Response Service. It's a hotline. It's a peer-to-peer hotline to encourage people to not use alone. One thing to note is that 60 to 70% of all drug poisoning events occur in someone's own home. And it's a population that doesn't necessarily reach physical supervised consumption sites. And so how the line works is that if you're using substances alone, you call a phone line and you get connected with a person of lived experience. They've walked the walk and they can talk the talk. And so they call this individual, they're on the line with this individual, and this individual takes down some key pieces of information. We'll take down some key identifiers. We'll take down your address, which is promptly deleted thereafter. And we're on the phone line with you, and we'll chat with you. We'll check in with you periodically if you need to. We joke around and provide education if need be as well. And if at any point in time during this phone call, if there's the caller's unresponsive and they're not responding to prompts, we initiate a response. And this response can either be EMS services, which we dispatch to your home, or we connect them with a family member, a friend, or community support member. And that's crucial. So sometimes, say they're in a harm reduction housing facility, we'll call the front desk of the harm reduction housing facility, where so someone can actually go upstairs and resuscitate the individual. That's how the program works in a nutshell. There's a few other programs that are out there as well. There's timer-based programs such as Lifeguard in BC and the Digital Overdose Response Service, which is out of Alberta. And so these services are actually an app on your phone. It has a timer function, and essentially the timer goes off if you're, I'm trying to see if I can use it here. The timer goes off and has a little bit of a countdown, and you just have to increase your volume here. And you start, and it has a little bit of a countdown that goes on there. And after about 30 seconds, it starts to get louder and louder and louder. And if you don't press refresh or extend, someone from STARS will get patched through and talk to you about it, talk to you and see if you're doing okay. And if you're not doing okay, then they will dispatch EMS services to your location. So it's a pretty decent program. There was some data that was just released around through a tweet, but I'll share some of the data that we have from NORS right now. And so in terms of barriers that these services remove, it removes the geographic distance barriers. So a lot of our clients can't access supervised consumption sites. They don't want to go outside when the wind is really bad, when the cold is there. And so they prefer to use at home. There's a lot of fear and stigma from people being seen in physical supervised consumption sites from some individuals. We get a lot of calls from lawyers, athletes, pro athletes, physicians who use the line. And so we can see that some of these individuals don't necessarily want to use a physical supervised consumption site. There's also a time barrier in terms of the service being provided to you. And so some supervised consumption sites throughout the country only operate from say 8 a.m. to midnight. And so this is an additional support for them when they're not open. And there's also sometimes limited mandates around supervised consumption sites. So for example, some sites don't allow for inhalational consumption routes. So people who smoke substances, which make up a good portion of our substance users. And so providing this is another option for them to use their substances safely. There is some limitations of the program, however. People might be drowsy and might be overdosing, and so emergency services may not be dispatched to them in time. And then for some jurisdictions of the country, police may not be able to, might show up to the call out, not in BC, but in Alberta this can. And the Good Samaritan Act, which is supposed to prevent any sort of harmful effects from people using substances and who call for help, it doesn't necessarily protect for people who might have a warrant for their arrest and who might have children on site because their children might get confiscated. So we do warn individuals about that. Paraphernalia might be confiscated and some people can overdose very quickly. But thus far, according to data, we haven't had a single death from NORS, and I'll talk about it in just a second. But most of our calls are supervised consumption calls. We do get mental health calls as well. One thing that we didn't expect from the phone line is that we do a lot of peer-to-peer support and mental health support. We do a lot of education, and we do a lot of psychosis de-escalation, again, which was not an intended aspect of our program. So a lot of individuals who are using crystal meth, for example, might go into acute psychosis, and we're able to sort of de-escalate the situation, provide some harm reduction education around these individuals. So we'll tell them to turn off the lights, turn off any sort of external stimuli, get some food, go to sleep, and sort of reorient them if needed, if they're seeing hallucinations or if they want to go outside so they don't get harmed. And so these are the things that the line is able to do because of the peers that we have who operate the line. Another interesting thing about the line is that the vast majority of our callers are gender minorities, so they're female or they describe themselves as being gender diverse, which is very different than physical suppressed conception sites. The vast majority of the physical SCSs are male, up to 80%, and so we are seeing a different population who uses these services. We've had 77 drug poisoning emergencies that have happened, none of which have caused a fatality. We do call up the callers afterwards to make sure they're doing okay. Sometimes they're in the hospital, sometimes they're back at home. There's been no fatalities to date, and we've had only 3 false alarms, which was another big concern that was brought up, is that we'd have tons of false alarms, EMS be showing up all the time, and that hasn't happened after almost 7,000 phone calls. The other thing too that we've noticed is that based on our data, a lot of our callers are calling from areas that couldn't access physical suppressed consumption sites because they were either closed at the time of call, they didn't allow for smoking or inhalational routes, or they lived in a city without a physical suppressed consumption service. I think it's really important to highlight that it's really addressing a population that doesn't have access to these needs. This is a paper that we're hopefully going to be coming out with. We resubmitted it yesterday after getting rejected, and so we're looking sort of at the association of routes of consumption and different demographics in terms of overdose risk when they're using the line. And the vast majority of people who are having a drug poisoning event while using the line are from BC, for example, are using the smoking and injecting route and, smoking and or poly routes, I should say. And interestingly enough, we're calling on a Tuesday, I should say a Wednesday, which is very interesting. I think that might be due to welfare checks coming out in some provinces, not all provinces, of course, but provinces such as BC and Manitoba, for example, have this. So I'm going to dive into harm reduction and acute care. This is a sort of a very important study that looked at, again, this is sort of from the prospective cohort that was done in Vancouver, and they looked at 1,000 participants who had experienced more than one hospitalization, and they found that 44% of this population were using substance while they were in hospital, and they were most commonly using inpatient washrooms, and really they were using in secret. And I think that's very important to highlight. And we've had complications from this already. At the Foothills Hospital in Calgary, we've had some complications from that. At the U of A, I remember being part of QAR where at the U of A hospital, UAH, we've had situations which we've had deaths because of this as well. And so it's really important to know that people are still using substances, whether we want them or not, to use substances in these settings, and we have to be as supportive as we can around them. And a lot of people are often discharged against medical advice without any sort of medical supports around this. And this leads to poor outcomes overall, leads to increased hospital admissions, increased overall hospital stays. If it's not, there's no harm reduction supports around them. This was from a qualitative study that was done in Vancouver, and they found that some of the barriers that people felt and some of the issues that people experienced in hospital was social and structural factors that led to inadequate pain and withdrawal management, secondary to stigma, led to their ongoing use in hospital, and attempts to regulate their use because they want to prevent themselves from having from having these withdrawal symptoms, and also it sort of amplify their risk of having poor outcomes thereafter. In terms of hospitals as risk environments, absence-only policies, inadequate pain and withdrawal management, and negative stereotypes often cause the initiation of involuntary discharge or patient-initiated discharge, I should say, inability to practice harm reduction there on the sites, and led to increased morbidity and mortality thereafter. And it really should be integrated in our acute care facilities. And so this is from a retrospective evaluation that was done in Boston, and they looked at 102 individuals who were different endocarditis. And in this facility, prior to the initiation of harm reduction and substance use management programs in the facility, they found that only 7.8% of individuals had a plan for medication-assisted treatment when they were there. Naloxone was never prescribed when they were discharged. And within 1 year's time, 26% of them had died from their infections or from other consequences from their substance use. And so this really highlights the need to have further supports for this population. And this is from another qualitative study, and they found that having these services on site provides and improves patient engagement. It causes prioritization of care retention, and really engages this population much better. And then it can be integrated in harm reduction facilities. And there's a picture of the Alex there. of course, and one of the big things to highlight is that suppressed consumption sites can happen there. So the Alex, and this is by, again, Catherine Donnelly and Hishka, they were able to establish a suppressed consumption site at their facility at the Royal Alex Hospital, which has been a huge benefit to clients in many respects, because they can engage in harm reduction supports while engaging with their healthcare needs and engaging with the other aspects that are required to support their wellness. So this includes, again, access to social services, includes mental health supports, all these other key pieces that help them be the best they can be. A thing that I'm working on, so another study that we just submitted is technology in acute care settings. And so during the pandemic, we had a lot of individuals who were in isolation. We had a lot of individuals who were using alone, and we had complications from that secondary to substance use. So we had individuals who were having drug poisoning events in washrooms, for instance. And so what we're looking at is technology in acute care services. And so there's different types of technology that are out there. We've got reverse motion detectors that we are hopefully going to be implementing soon in some of these sites. And we have funding for wearable technology, smartphone applications such as the Doors app and the Norris phone line, and overdose response buttons, in which someone just presses the button if they're about to use. And if they don't press the button again thereafter, someone will come and check in on them. And we've done some qualitative evaluations around this. We looked first at providers. And so we interviewed about 16 providers in BC and in Alberta at various different sites, such as St. Paul's and RGH and UAH, and also the Royal Alex. And some of the themes that we found was that in terms of patient care, they found that this is really an acceptable intervention. There was some concerns that if you had these technological pieces, some rapport building could be difficult, but that stigma reduction can happen. And what they meant by that was that with the physical supervised consumption sites, people actually engage with wellness supports with things such as reverse motion detectors in rooms where people might be suspected of using, but not necessarily being open about that. That rapport may not be necessarily built, and you don't engage with the client as much. In terms of healthcare workers, the impact on healthcare worker burden might be positive. So we do hear stories, say, for example, on Unit 36 at the Foothills Hospital, we have nurses who will check on clients every 15 minutes just to make sure they're doing okay. And that really disrupts their workflow. And so having these services available on site can be helpful. But that sometimes stigma buying from healthcare providers could be difficult. And then from system level changes, there's some concerns about coordinating emergency response. So if there was a drug poisoning event, how do you respond to that? And there's also policy and legal issues, which is what we've run into actually here with the AHS, is that a lot of times there's misconceptions around substance use. So we've had to sort of go through the legal rigmarole of saying that this doesn't necessarily enhance people's substance use. This doesn't encourage people to use substances. This doesn't say that that we're overlooking what's going on. It's just really providing a holistic approach to harm reduction in acute care settings. In terms of things that we can do around harm reduction in acute care settings, we can do standardized intake and assessments, do a comprehensive addiction management evaluation, provide health promotion, talk about social determinants of health, and provide community connections thereafter. But I really think it's important to sort of talk about some other aspects of harm reduction. And so I got this from a paper in the Journal of Harm Reduction, and it really talks about pragmatic ways that you can introduce harm reduction into your facility if you don't actually have a harm reduction service. And so some of the things that you can do as a provider include providing and recognizing that someone is human, being pragmatic around their care, encouraging their individualism, encouraging their autonomy, and looking at incrementalism. And what I mean by that is that sort of looking at any sort of positive step towards improved health as a positive change, and not reprimanding them if there's a step back. Say they start using substances again, you don't reprimand them. You don't use negative consequences. You don't force accountability. And you don't fire them. It's all about being supportive for their use and encouraging them to do be the best that they can be. So here's some other things that I found from the literature as well in terms of harm reduction that we can implement here. And so this is a bit more program implementation. So in terms of alcohol education, encouraging individuals to decrease during the day, decrease the number of drinks they take, eating before drinking, alternate water with alcohol, create a drinking tracker card, which we do in our clinics, and make a safer drinking play. So such as, for example, if they are at risk of driving by themselves, have lock card keys, carry condoms so they're be engaging in risky sexual activity, providing medications such as naltrexone, recovery-oriented flyers, and detox information. In terms of stimulant education, what we often tell individuals is to like we educate them on the importance of eating, ensure that food and water intake is there because often their appetite is reduced from stimulant use, educate on the importance of sleep. So we know one of the biggest risk factors, for example, for psychosis from methamphetamine use is the lack of sleep. Tell them not to combine substances such as cannabis and stimulant use, which is also another huge risk factor for psychosis. Carry condoms for individuals who engage in chemsex or party in place. We do have within the MSM population this phenomenon where individuals use crystal meth and engage in risky sexual behavior. So it's educating around that, providing PrEP, for example, as an anti-HIV or HIV prophylaxis, and using sterile supplies and using safe supplies such as rubber pipe mouthpieces, because sometimes individuals might burn their lips, which is a risk for Hep C transmission if they're sharing supplies, and using steel wool use, for example, to clean out their kits. And also in terms of other supply support, providing needles, cookers, tourniquets, cotton balls, vitamin C to acidify their substances that they're using, education, fentanyls, test strips, condoms, and naloxone kits. These are all crucial pieces that you want to provide to individuals where you can in hospital facilities. The other key thing that I really want to stress that we can do right now to help support this population where they're at is using people first language, and language is important. And so language is evolving. We know that terms such as, and I say this, is addict, drug abuser, dirty, unclean, non-compliant are all very harmful, stigmatizing languages. And we're really moving away from that. We're talking about language such as someone who uses substance use, or someone who has a substance use disorder, or someone who uses, or people who use substances. That's my preferred term. They live with a process, or they have a history. They're not that. They're not a person with the HIV. They have someone who lives with HIV. It's not their identity, and so that's what we really want to highlight. So those are the terms I'd like to use. Even the term active in addiction is something that I try not to use either. We again are moving towards stigma-free language, and it's really important to sort of implement that in our day-to-day work. I'm open to questions right now, but before we do that, I just want to make a couple announcements. For those of you who are interested, we are going to be launching an ECHO-like program for substance use for all providers. So this includes physicians, nurses, pharmacists in the community and in acute care settings. This is going to be launched in August through Alberta Health Services. Recently, there was addiction grand rounds that was launched through the Edmonton zone and Calgary zone. So feel free to email me for information on that. There's also an expansion right now. So in Calgary, I should say, we have the Rapid Access Addiction Medicine Program. So we deal with all substances such as alcohol, gambling, sex, cannabis, stimulant use, and we're very much focused in Calgary zone, but we will be expanding province-wide, minus Edmonton for the time being in the near future. So if you've got rural clients that can access this program, and just email me for more information, I can probably send a memo on that as well. And then we're also going to be providing support around addiction consults to the Rapid Access line. And so that'll be 9 to 9, 7 days a week, all ready to provide support for opioid agonist treatment with a virtual ODP program, so the opioid dependency program, but we'll be expanding that to provide supports for alcohol, any other substances, whether it's behavioral addictions or substance use disorders. So things to sort of mention there. And I want to acknowledge that some of these slides did come from Karine Meador and Carlene Reddy. And so I really am grateful for the ability to use these slides. And thank you again for allowing me to present today, and happy to answer some questions.
Goodness, thank you so much for such a great talk. I don't know if anybody has any questions in the room. Okay, Dr. Houston.
Hi, Monty. Wow, you really covered the waterfront there in 45 minutes. That was fantastic. So I will resist the temptation to ask you what you think the future of harm reduction in Alberta for the next 4 years will be following this week's election. But I would ask you, are there any promising developments in the whole stimulants or amphetamine use in terms of management and treatment?
Great question. So in terms of management, what we're doing right now for stimulant use is we're providing the only really strong evidence-based around this is what's called contingency management. So it's a ward-based system, and we have that set up in Calgary. So people who are using stimulants and have demonstrated engagement with their program are provided this sort of reward system where it's called a fishbowl mechanism, in which they are able to get rewards through every time that they engage with our treatment programs. And so that's the only evidence-based service that we have right now. It was formerly based on urine drug screens, but we're trying to move away from that. But we are using stimulant harm reduction pharmacotherapy. So I use that quite a bit. We've got meds such as buprenorphine, bupropion, I should say, Wellbutrin, and also topiramate that's out there, mirtazapine. These are all meds that you can use to sort of decrease the overall consumption of stimulants. And so it doesn't cause abstinence. So we have data that shows that, and a lot of the studies were focused on abstinence and saying that there was no positive outcomes for people who are on these versus not, but there was an overall and statistically significant reduction in overall use. So I'm personally using this more and more as a harm reduction tool. But it's not always there. But in terms of traditional aspects of dealing with stimulant use disorder, it's really about engaging with the psychosocial supports. It's maximizing their mental health, working on them to reduce any sort of episodes of psychosis that can possibly occur, and educating them on safer use consumption practices. So that's what we're kind of focused on with this, and I'm hopeful. Although, I think we need to all collectively push for more harm reduction supports around the province. I think it's important that we highlight that, and I appreciate you making that comment. That even now more than ever, is that we need to focus on this, and we need to make sure that it's a priority amongst the other aspects of the recovery-oriented systems of care in our province.
There's a question in the how does last week's provincial election affect your ability to provide this important and evidence-based care?
That's a tough question. So, one thing that the government has done is that they've really incorporated a broad systems of care for substance use. They've very much focused on the recovery aspect, but they, and I'll be just frank here, they have increased funding towards harm reduction services as well by 3 times. So the funding has been up by 75%. Now, what my concern with and I guess this is being recorded, but my concern right now is the mixed messaging that we see here. You see that there's these panels against supervised consumption services. There's a panel against safe supply. There's this sort of mixed messaging that harm reduction is important because they provide funding towards it. Yet at the same time, they're providing public messaging that's not necessarily beneficial. They're investing in more supervised consumption sites. They're investing in apps such as the Doors app. Yet the messaging is conflicting. So it's very, very difficult right now. I'm hopeful that they change that messaging and that they have more clear messaging that this is important. The one thing that I got to say is that one thing that I don't want to see is mandated treatment. I think that the evidence for that is fairly poor. And there's lots of legal and ethical issues around that as well. And we don't need to go down that path. But again, there's a lot of positive things that this government has done. They're looking at decriminalization in some respects. They're focused on investing more than any other government before it in substance use management. I think to the tune of 280 million. So some positive things, but again, the messaging needs to be on par with what we're seeing with the evidence, and hopefully that will come in the future. I think the conversation starts with us though, right? As healthcare providers. So hopefully we can push that forward.
Thank you. There's another question here. Asset-based community development, which health systems are moving towards, does not segment people into drug user, mentally ill, senior, etc., but rather considers everyone as part of the community. They are part of us. Experience shows this changes attitudes and introduces compassion and concern. Can you comment?
Totally. I think that's the key here. So like my favorite story to share, and maybe I can do it in a minute or less, is the Rat Park story. And I think that's really important for us to be supportive as a community for individuals. So the Rat Park story in a nutshell is an experiment that was done in Montreal in the 70s. They took rats and they put them in a box, and they had 2 drips, a water drip and a heroin drip. And they found that the rats were by themselves, used the heroin drip until they died. But when they put these same rats in what was called Rat Park, where there's other rats, there was games there was food there, they could interact with each other, that only 10% of those rats used the heroin drip, which was also there. They still had the heroin drip and the water drip, but only 10% of the rats used the heroin drip. So how does that translate to humans? So during the Vietnam War, we had lots of US soldiers who were in Vietnam. They were using opioids and opium in particular, because opium was much more readily available than tobacco. And so there's this big fear that when these soldiers returned to the United States, that they would continue to use opioids, and it would lead to an epidemic of sorts. But they found that was not the case. And that was because these soldiers, despite all the trauma that they faced in Vietnam, all the deaths that they saw, were engaged with their community. They were engaged with their families. They were engaged with their jobs. They were seen as heroes by many, as veterans. And so they found that only 10% of that population, again, started using or continued to use substances when they returned. And so I think, to your point, it's important that we are as supportive and there for this population as possible. They are part of the community. We're part of the community as providers, and really recognizing them as being no different, and that and this is sort of the trauma-informed lens as well, and understanding that they come from a place that's potentially from trauma, from different circumstances, and recognizing that and being supportive of that is crucial to their wellness, also the community's wellness. We're starting to recognize that substance use concerns, I mean, we're not starting to recognize this, but I think it's becoming much more prominent in the eyes of the public, that substance use concerns really does reflect on the overall wellness of the community. And so being able to provide support around that does have huge repercussions and impacts on the rest of the community. And so it starts with us.
Thank you. Any other questions online or in the room? Maybe I'll ask one. If you had the resources to do one thing in Alberta that would make a difference beyond what you're already, the many things you're already doing, what would you do?
Oh, that's a tough question. I don't think there's a one-stop shop solution, unfortunately. We really need to have a whole systems-based approach to this. So whether that's providing more supports around drug checking, providing supports around harm reduction, providing supports around entering into treatment and opioid agonist treatment, these are all necessary pieces. It's really meeting the client where they're at. And we know that there's different stages of change for individuals. Some of them might be ready to engage with wellness support. Some of them are not ready to engage. We know that social determinants of health are crucial for this population, providing mental health supports. So unfortunately, I can't say there's one thing that we need to focus on. Is there things that we can improve upon? Absolutely. I think one of the things that I'm hoping for is decriminalization of substance use as a huge policy change. But we need as many resources as possible to deal with this crisis. And it really is a huge issue. We've had more deaths due to drug poisoning events than we've had because of COVID. And I think we need to highlight that, when we had so many resources put towards the pandemic, and yet there's this lack of support around the drug poisoning crisis in general, especially by the public. There's a blind eye that's often turned towards it. So I think it's very important that we provide more supports around this.
Thank you. There's another question. Harm reduction needs to be rebranded. It is worth serious consideration about how to change the language to something that gets away from the past and towards something that will be more palatable, health promotion or something to that effect.
I absolutely agree. I think that's important. I think, for me, it's all about improving quality of life, and health promotion really encompasses that term. So I appreciate that, Dr. Jaffe. I think that's absolutely crucial and absolutely necessary. And I think, again, but through our own internal education, we can help provide that change. I don't know about you, Dr. Ringrose, but we were never taught harm reduction in med school here in this province. We were never taught about addiction management. And so I think it's important that we're highlighting this, and it's a change in concept. It's a change in philosophy. I grew up in the days where drugs were bad, and don't do drugs, and that, this is your brain on drugs, and we really need to move towards decreasing that stigma around it.
There was someone with their hand up.
Oh, I'm sorry. There's someone.
I can set it for them to be able to.
Perfect. Yeah. Yeah, go ahead. There's someone in the chat with their hand up. Okay. Oh, go ahead. Jaya Pillai. Go ahead and speak. Okay. Okay, I'll read. Thanks, Dr. Ghosh, for the wonderful talk. Opioid overdose is something which happens with all class of society. Could you please comment on if there is any studies on which group of people use these services the most? It is being accessed more by our adolescent or youth population. Have they become more acceptable to the harm reduction services? Thanks.
Sorry, I missed that first part of the question. I apologize. Which harm reduction service in particular?
Could you please comment on if there are any studies on which group of people use these services the most? Is it being accessed more by our adolescent or youth population? Have they been more acceptable to the harm reduction services?
Really good question. I don't know too much around the literature around youth and adolescents around harm reduction. But I do know, at least for the physical supervised consumption services and the needle exchange programs, that's really our most vulnerable that are accessing those services for the most part. So it's those who are experiencing homelessness, who have no other access to healthcare resources, who don't necessarily engage with us because of stigma and because of previous experiences. And so we're, that's a portion of the population that it targets. But we're seeing differences in terms of like, so for example, with NORS, the vast majority of our callers are people who are stably housed, who are gender minorities, who don't necessarily access physical supervised consumption sites because of one barrier or another. And so we're seeing sort of a shift. But I think the more we make harm reduction available, the more it'll be utilized by the breadth of populations, whether that is youth, whether that is seniors, whether that is someone who's not experiencing homelessness. We just need to educate and advocate for this more and more. I think with youth in particular, they don't get exposed to the benefits of harm reduction. And so maybe that's why they're not accessing it more. And so we need to make that messaging clear, I think, in the public, through public health messaging, this is very important. And that there's supports available. And it's about the whole systems of care, not just harm reduction. It's about treatment as well that's available, mental health supports, dealing with mental health issues, dealing with trauma. These are all things that we have to have there to support this population.
Wonderful. Well, thank you so much for a wonderful talk, and have a great weekend, everybody.
Thanks again. Thanks for having me here.
Thank you.